Welcome to this important lecture on cardiovascular disorders, a critical topic in pediatric health that demands timely recognition and care. This session is presented by Professor Dr. Muhammad Amir Memon, renowned pediatrician from the Department of Pediatrics, Faculty of Medicine and Allied Medical Sciences, Isra University. Cardiovascular disorders are among the leading causes of morbidity and mortality in children across the world. Understanding their nature, causes, and management is essential for every medical professional. In this comprehensive session, Dr. Amir Memon will cover the structure and function of the cardiovascular system, common congenital and acquired heart diseases in children, diagnostic tools and modern treatment options. This lecture is especially valuable for medical students, pediatric trainees, and healthcare professionals seeking in-depth knowledge in pediatric cardiology. Stay focused, take notes, and enhance your clinical insight as we explore the complexities of cardiovascular disorders in children. Fetal and neonatal circulation. In utero, the fetus relies entirely on the placenta for respiratory gas exchange, nutrient delivery, and waste elimination. Oxygenated blood, enriched through placental diffusion, enters the fetal systemic circulation via the umbilical vein, which serves as the primary conduit of high oxygen and nutrient-rich blood. Upon entering the fetus, this blood follows a dual route. A portion is directed to the liver, allowing limited hepatic perfusion essential for metabolic priming. From there, it drains into the inferior vena cava through the hepatic veins. The remaining volume bypasses hepatic circulation via the ductus venosus, a vital fetal shunt, enabling the blood to circumvent hepatic filtration and flow directly into the inferior vena cava. This structural adaptation ensures the preservation of oxygen saturation for preferential delivery to vital organs. In the inferior vena cava, this stream of oxygenated blood mixes with deoxygenated venous return from the lower extremities and abdomen, forming a composite flow that enters the right atrium. Within the right atrium, fetal circulation exhibits its most intricate shunting mechanism. Approximately one-third of the blood, particularly the better oxygenated stream, is directed through the foramen ovale, a septal opening between the atria. This shunt allows the blood to bypass the right ventricle and enter the left atrium, then the left ventricle, and finally the ascending aorta, thereby ensuring that oxygen-rich blood reaches the coronary arteries and cerebral circulation with maximum efficiency. The remainder of the blood in the right atrium, which includes relatively deoxygenated return from the upper body via the superior vena cava, is funneled into the right ventricle and then ejected into the pulmonary artery. Due to high pulmonary vascular resistance in the fluid-filled fetal lungs, only a small fraction of this blood enters the pulmonary capillaries for minimal perfusion, primarily supporting lung development rather than gas exchange. The majority of the pulmonary artery output is diverted through the ductus arteriosus, a critical vascular channel connecting the pulmonary artery to the descending aorta. This physiological right-to-left shunt enables systemic blood to bypass the non-functional lungs and instead supply the lower body and placenta, thus completing the fetal circulatory loop. These specialized shunts, the foramen ovale, ductus venosus, and ductus arteriosus, are essential for fetal survival. Postnatally, they undergo functional closure in response to hemodynamic changes and increased oxygen tension, marking the transition to neonatal circulation where pulmonary respiration takes precedence. Transition to neonatal circulation. The transition from fetal to neonatal life represents a dramatic shift in the newborn's circulatory physiology. At birth, as the infant takes the very first breath, the lungs expand and fill with air. This results in a significant rise in arterial oxygen tension, PaO2. The elevated oxygen levels initiate a rapid decline in pulmonary vascular resistance, leading to a marked increase in pulmonary blood flow. As more blood returns from the lungs to the left atrium, the left atrial pressure rises, eventually exceeding that of the right atrium. This reversal in pressure causes the functional closure of the foramen ovale, a fetal shunt that previously allowed blood to bypass the lungs. At the same time, with the clamping of the umbilical cord and detachment of the placenta, the low-resistance placental circuit is eliminated. As a result, systemic vascular resistance rises, further supporting the redirection of blood through the now functional lungs. Another major change involves the ductus arteriosus, the vessel that connects the pulmonary artery to the descending aorta in fetal life. This duct begins to close shortly after birth. Functionally, this closure is triggered by two key factors: a rise in oxygen tension and a decrease in circulating prostaglandin E, PGE2, a hormone that maintains ductal patency in the fetus. Anatomically, the ductus arteriosus undergoes fibrotic remodeling, sealing off permanently and forming the ligamentum arteriosum. Together, these physiological changes complete the transition from placental to pulmonary gas exchange, establishing the fully functional neonatal circulatory system, which now operates independently from the maternal environment. Congenital heart disease. Congenital heart disease represents a structural abnormality of the heart or great vessels that is present at birth. The cause of congenital heart disease is usually unknown, but in individual cases, evidence points to a multifactorial etiology, with the insult probably occurring in the first 8 weeks of gestation, a critical period during which the fetal heart is forming and developing its structural components. Over the years, several teratogenic factors have been identified and associated with an increased risk of congenital heart disease. For example, maternal medications, such as folic acid antagonists and certain anticonvulsants, have been implicated in disturbing early cardiac development. Maternal infections, particularly rubella, have long been recognized as a significant risk factor during early pregnancy. Maternal diabetes mellitus has also been strongly linked with a higher incidence of structural heart defects in the fetus. In addition to environmental and maternal factors, congenital heart disease may also be a component of several genetic syndromes, including Down syndrome, which is commonly associated with atrioventricular septal defects; Turner syndrome, where left-sided heart defects, such as coarctation of the aorta, may be present; and Marfan syndrome, a connective tissue disorder often linked to abnormalities of the aortic root and valves. These associations underscore the complexity and varied origins of congenital heart disease, highlighting the importance of early screening, genetic counseling, and prenatal care. Acyanotic heart diseases. Acyanotic heart diseases are congenital cardiac anomalies in which there is no mixing of deoxygenated blood with systemic circulation, and therefore, cyanosis is typically absent in early stages. These conditions are usually characterized by left-to-right shunts or outflow obstructions, leading to volume or pressure overload on the heart, depending on the lesion. We classify acyanotic lesions into 2 main categories based on their physiological effect. First, we have acyanotic lesions resulting in increased volume load, which lead to excessive blood flow through the pulmonary circulation. These include ventricular septal defect, VSD, the commonest of all congenital heart diseases, where there is an abnormal opening in the interventricular septum, allowing blood to flow from the left to the right ventricle. Patent ductus arteriosus, PDA, a persistent communication between the aorta and pulmonary artery after birth, resulting in continuous left-to-right shunting. Atrial septal defect, ASD, a defect in the interatrial septum, permitting blood flow from the left atrium to the right atrium. These lesions primarily cause volume overload, which may lead to pulmonary overcirculation, chamber dilation, and eventual heart failure if left untreated. Secondly, we consider acyanotic lesions that result in increased pressure load, which are characterized by obstruction to ventricular outflow. These conditions include valvular pulmonic stenosis, where the narrowing of the pulmonary valve restricts outflow from the right ventricle; valvular aortic stenosis, involving narrowing at the level of the aortic valve, causing increased pressure load on the left ventricle; coarctation of the aorta, a congenital narrowing of a segment of the aorta, typically just distal to the origin of the left subclavian artery, leading to upper body hypertension and lower body hypoperfusion. These pressure overload conditions may lead to ventricular hypertrophy and long-term cardiac dysfunction if not diagnosed and managed early. Understanding these classifications is crucial for guiding appropriate diagnostic evaluation and intervention strategies in pediatric cardiology. Cyanotic heart diseases. Cyanotic heart diseases are a group of congenital heart anomalies characterized by right-to-left shunting or complete mixing of oxygenated and deoxygenated blood, resulting in cyanosis, a bluish discoloration of the skin due to reduced oxygen saturation in systemic circulation. Among these, several complex lesions significantly impact both pulmonary and systemic blood flow. One such condition is total anomalous pulmonary venous return, TAPVR. TAPVR is associated with total mixing of systemic venous and pulmonary venous blood flow within the heart, and thus produces cyanosis from birth. In this anomaly, the heart has no direct pulmonary venous connection to the left atrium. Instead, the pulmonary veins may drain abnormally into the right atrium or into systemic venous structures, leading to complete mixing of oxygenated and deoxygenated blood before it is circulated. Another cyanotic defect is truncus arteriosus. In this rare but severe condition, a single arterial trunk, known as the truncus arteriosus, arises from the heart and supplies the systemic, pulmonary, and coronary circulations. A ventricular septal defect, VSD, is always present in this anomaly, and the truncus overrides the septal defect, receiving blood simultaneously from both the right and left ventricles. This mixing of blood leads to chronic cyanosis, as well as volume overload of the pulmonary circulation, eventually resulting in congestive heart failure if left untreated. Both of these lesions require timely diagnosis and surgical correction, as they are incompatible with long-term survival without intervention. Thank you. If you missed any point during today's lecture, don't worry, you can always catch up. The full-length video is available anytime on my official YouTube channel, Prof. Dr. Muhammad Amir Memon. Be sure to subscribe, explore more academic content, and stay updated with upcoming lectures and medical discussions.